to our lecture about shock, in particular pediatric shock, based on Walsh's 6th edition, chapter 27. What you will learn. You'll learn how to define shock and other key elements of shock physiology, as well as understand the concept of oxygen delivery and consider how to select this in pediatric clinical cases. You'll also learn by the end of this you should be able to recognize the clinical presentation of some select shock states that affect the pediatric population, and describe basic principles in their management and treatment. But also you should be able to identify the necessary elements of diagnosing and treating pediatric patients with meningitis. So let's jump right into it. What is shock? Shock is the disruption of natural homeostasis that exists within the body to ensure adequate oxygen delivery to all of its tissues. In this abnormal metabolic state, the body isn't able to maintain a sufficient supply of oxygen out to all the organs, despite the increased demand. This results in a complex cascade of compensatory mechanisms designed to restore homeostasis or balance. When formally defined, shock represents an acute abnormal physiologic state characterized by inadequate delivery of oxygen and other nutrients to meet metabolic demand. In some shock states, there may be impaired oxygen utilization despite enough being delivered. And at a cellular level, these derangements result in less efficient energy metabolism with diversion to secondary metabolic pathways like anaerobic to maintain cellular function. When shock is left unchecked, cellular function is severely compromised and can result in cell death and a refractory shock state. If shock is reversed, tissue oxygenation is restored. Organs and organ systems can function better. Although there are common features that characterize shock states, it is of value to talk about some of those different shock states. Let's start with hypovolemic. Hypovolemic shock is low volume shock state with intravascular volume loss as a cause. Examples of it include severe dehydration and hemorrhage, leading to hemorrhagic shock, and also resulting from diabetic ketoacidosis. Cardiogenic shock. As the name implies, it describes primary failure of the heart, the pump that puts all the blood around the body. In children, cardiogenic shock may be observed after cardiac surgery or from primary disease processes like myocarditis or cardiomyopathy. However, there are many reasons for cardiogenic shock, making diagnosis and treatment of the underlying cause a challenge. Obstructive shock. Obstructive shock is characterized by a shock state in which a physical obstruction to blood flow impairs cardiac output and ultimately oxygen delivery. Examples of this include cardiac tamponade, a tension pneumothorax, or even pulmonary emboli. In this type of shock, intravascular volume and myocardial function are normal, but there is some kind of obstruction to intrathoracic blood flow that impedes the heart's ability to pump blood and oxygen to the body. The final and perhaps the most broad category of shock is distributive shock, which includes shock states such as sepsis, anaphylaxis, adrenal crisis, and neurogenic shock. Each of these shock states is characterized by a maldistribution of blood flow to tissues with resultant low systemic vascular resistance states. Whether mitigated by cytokinin release by an infectious organism, or histamine release secondary to allergen exposure, or loss of sympathetic tone from decreased adrenergic or neuronal control, each of these shock states results in insufficient oxygen delivery or underutilization to meet the body's metabolic demands. Given the significance of septic and anaphylactic shock to morbidity among pediatric patients, this chapter will discuss those two shock states more extensively. Let's start with sepsis. Sepsis or sepsis syndromes are life-threatening organ dysfunction caused by a dysregulated host response to infection. In other words, an overwhelming infection throughout the body. Septic shock is a subset of sepsis. In which underlying circulatory, cellular, and metabolic abnormalities are associated with greater risk of mortality than sepsis alone. Septic shock, which is a common cause for admission to PICU or pediatric intensive care units, is often a complication of decreased volume or hypovolemia and has distributive and sometimes cardiogenic shock features. Early septic shock can often be managed with volume resuscitation, giving fluid, antimicrobials, and supportive therapy. However, once it progresses, it may require vasoactive support, which we'll talk about a little later. Late or refractory septic shock may or may not respond to fluids and catecholamines and may rapidly progress to multi-organ failure and death. The key to management of septic shock is early identification, early intervention, and appropriate antimicrobial treatment. So knowing what the organism is and treating it early with the right antibiotic. Anaphylaxis. This is a second type of distributive shock that results from peripheral vasodilation. Anaphylaxis, or anaphylactic shock, occurs when a foreign antigen, like a bee sting that you're allergic to, interacts with the body and elicits a systemic immediate hypersensitivity reaction caused by an immunoglobulin or IgE. This is a mediated release of mediators from tissue mast cells and circulating basophils. A variety of substances can elicit these reactions. There are times, however, when the cause of anaphylaxis may not be found despite a search. After an introduction of an antigen into the body, either by internal or external route, reaction, either they eat it or they get a bee sting or something like that, a bunch of things happen. One of the main things is that histamine is released and is one of the most prominent mediators and is believed to be responsible for an increase in airway resistance, a tightening of all the airways, and a fall in the partial pressure of oxygen as a result of the smooth muscle of the lung and all the bronchioles contracting. So it all tightens down. There's a rapid loss of intravascular volume, which then stimulates the release of catecholamines. Initially, systemic vascular resistance is reduced and cardiac output is increased, but prolonged shock, these can be reversed and decrease. There can be a decrease in preload, and afterload leads to myocardial depression and cardiovascular collapse. So, you can see skin eruptions, edema, swelling, respiratory compromise, and cardiovascular collapse, depending on the severity of the symptoms and how allergic they are to whatever they got into. Once the air, you need to make sure that there's prompt initiation of therapy. Treatment of anaphylactic shock can be divided into two phases. First, make sure that you deal with the CABs, circulation, airway, and breathing. Airway compromise may be present and takes priority, so securing the airway is primary and making sure the patient is breathing. Making sure circulatory dysfunction and shock are the next most pressing issues. For circulatory collapse, large volume infusions like an IV, as in other types of shock, can help to restore circulating blood volume. Hypotension can be severe and resistant to therapy. Circulatory support with repeated doses of epinephrine and or a continuous epinephrine infusion can help to support the patient until directed therapy can begin. Once vital functions have been restored, then attention should turn to combating whatever antigen started this all. Let's talk about the pathophysiology of shock. There are some key pathophysiologic things going on. Two key pathophysiologic things that go wrong are impairment of oxygen delivery and utilization of oxygen by the cells. Two things that contribute to that are cardiac output. Without cardiac output, oxygen can't be effectively delivered to body tissues. So what is cardiac output? Cardiac output is the amount of blood pumped from the heart to the organs and the tissues of the body. It can be expressed as liters of blood per minute pumped by the heart. However, children are very different from each other even when they're the same age in terms of their size. So all hemodynamic measurements need to be corrected for size differences. When cardiac output is corrected for size, it's called cardiac index. Cardiac index is equal to cardiac output divided by body surface area. In children, normal values for cardiac index range from 3.3 to 6.0 liters per minute per meter squared. A cardiac index of less than 2 has been associated with an increase in death. The cardiac output is determined by both heart rate and stroke volume. Heart rate is simply how fast the heart beats per minute, and stroke volume is the amount of blood pumped out by the heart with each mechanical stroke. Next, let's talk about the components of stroke volume: preload, iantropy, and afterload. Preload is measured as the central venous pressure and is a representation of the amount of volume in the heart and the great vessels, and is dependent on adequate venous return. Ionotropy is a term that characterizes the contractile state of the heart muscle, or how well the heart is pumping, how well it can contract. Ionotropic problems may occur despite adequate preload if the contractile state is compromised. Afterload is a measure of resistance against or force against which the heart must pump. Resistance to flow of blood in a vessel is proportional to the length of the vessel and the viscosity of the blood, and inversely proportional to the radius of the vessel to the fourth power, all based on Poiseuille's law. Cardiac output is responsible for transporting blood and nutrients from the heart to tissues and organs and back again. Nutrients are carried in the blood by two different methods. First, some are carried dissolved in the blood. Some nutrients and oxygen are dissolved in the blood. Secondly, nutrients and oxygen can be bound to red blood cells or carried by the cardiac output to the tissue. Oxygen delivery depends significantly on how much hemoglobin there is, or the hemoglobin concentration. The amount of oxygen bound to hemoglobin is described by the oxyhemoglobin dissociation curve and is affected by physical properties like temperature and acidosis. The body's response to poor tissue perfusion, or metabolic response, results in a number of metabolic reactions. Many manifestations of shock represent the body's compensatory mechanisms, which attempt to maintain tissue perfusion and correct abnormalities of shock. These responses attempt to maintain a mean circulatory pressure, maximize cardiac output, redistribute perfusion to the most vital organs like the kidneys and the brain and the heart and the lungs, and optimize unloading of oxygen at the tissues. The central nervous system releases adrenocorticotropic hormones when we are stressed, which stimulates the adrenal glands to release cortisol. Adequate adrenal cortical function is essential to survive critical illness, and most critically ill patients will exhibit elevated cortisol levels. Many patients, however, exhibit a state of relative adrenal insufficiency because there isn't enough production of cortisol. Management and treatment of shock. Some general considerations. The overall goals of treatment of shock are to maintain adequate tissue perfusion, avoid end organ damage, and treat whatever the underlying primary process is. Therapeutic strategies should enhance delivery of oxygen and nutrients to the tissue, reduce oxygen demand, and correct metabolic abnormalities. Continuous monitoring of the patient's response to interventions is critical and may lead to redirection of therapies. Early aggressive therapy for shock focused on maintaining blood pressure and oxygen delivery improves outcomes in critically ill children. Assessment and evaluation. The approach to the child in shock begins with an evaluation of vital functions. Maintenance of the airway and attention to oxygenation and ventilation are the initial priorities no matter what type of shock. The presence and quality of pulse reflects systemic vascular tone as well as cardiac output. If a pulse is absent, CPR needs to be performed, and cardiotonic medications like adrenaline need to be started that are consistent with advanced life support. Vascular access should be rapidly obtained either through a vein or interosseous method, or even a central venous route. Once you've established airway, breathing, and circulation, then attention should be directed to measuring vital signs and performing a secondary survey. Normal values for pulse, respiratory rate, and blood pressure are age-dependent, so you need to know these age-related differences, which is essential to medical care for the pediatric population. Healthcare providers should evaluate the patient's systemic perfusion, which reflects the effectiveness of cardiac output. Capillary refill, the process of blanching the skin for several seconds and timing the return of blood flow to the blanched skin, is a quick and useful and non-invasive way to assess this. The normal capillary refill time should be less than 2 seconds, which correlates with a cardiac index of more than 2 liters per minute per meter squared. If there is prolonged capillary refill, it should be a sign of inadequate tissue perfusion and impending or ongoing shock. You should then evaluate the skin, brain, and kidney because there are easy clinical assessments to perform. Evaluation of skin and skin temperature is easily performed by looking and touching the skin. Children in shock may be pale, cyanotic, or mottled and blue with poor perfusion. In early stages, they may be warm and pink. In later stages, cardiac output begins to fall, so the skin is likely to be cool and clammy and cyanotic or mottled. Next, the child's mental status should be looked at, particularly the level of awareness, orientation, and response to command. Using the Glasgow Coma Scale may be a useful tool to gauge the child's mental status as well. Monitoring the child's urine production assesses perfusion for the intra-abdominal organs. If the child is making at least 1 ml per kilogram per hour of urine, then cardiac output to the kidneys is adequate and renal blood flow is considered adequate. Both kidney and brain need to be perfused. If the urine is less than 1 ml per kilogram per hour, shock is classified as decompensated shock, and in decompensated shock, blood pressure falls and there is compromise to end organ perfusion. Laboratory values can often provide useful clues to proper diagnosis. Evaluation of acid blood status, including electrolytes and a blood gas, preferably arterial, with a calculation of the anion gap are important first step. As shock progresses, a metabolic acidosis and an elevated lactate level may occur. Lactate is a measure of the anaerobic metabolism and is often elevated in shock, but can also be elevated in many conditions in the absence of shock. Anemia, thrombocytopenia, and an elevation in PT and PTT may identify a coagulopathy or a disseminated intravascular coagulation or DICs. An elevated or reduced white blood cell count, leukocytosis or leukopenia, respectively, may indicate the presence of infection or immunodeficiency. And elevated liver enzymes or serum creatinine may suggest a problem with the liver or kidneys. An electrocardiogram and chest radiograph are often obtained in initial evaluation for the cause of shock as well. Monitoring. Monitoring is ongoing assessment and is required for a child in shock. You should assess, intervene, and then reassess. Attention to the effects of the intervention on vital signs and end organ perfusion must be continually observed. A number of technologies are available in PICU for assessing and monitoring a child in shock. These techniques will augment information derived from vital signs and physical exam. The arterial catheter, or CVP monitor, and pulmonary artery catheter are three of the most common strategies used to detect physiologic changes and supplement the clinical assessment of a child in shock. The placement of a catheter in a peripheral or central artery can be performed for monitoring blood pressure on a continuous basis in PICU. Because the left side of the heart receives its blood from the right side of the heart, the measurement of right-sided heart pressures is accepted as an alternative for measurements on the left side of the heart. CVP measurements closely reflect PA wedge pressure. This information helps the provider to diagnose and treat a patient in shock if the CVP is high in the setting of normal myocardial compliance, then intravascular volume is adequate and may not be accounting for the reduction in cardiac output. The CVP may be elevated if blood is unable to be ejected because of a failing myocardium. If the CVP is low or central venous pressure is low, additional intravenous fluids may need to be given to improve intravascular volume. A central venous catheter also provides easy access for blood sampling, measuring mixed venous oxygenation, and provides access for rapid fluid resuscitation and giving medications. A PA catheter in children has been debated, but in children with fluid refractory and dopamine-resistant shock, a PA catheter may provide additional information. The use of PA catheters in children is supported by the American College of Critical Care Medicine for circumstances in which irreversible shock, manifesting as poor perfusion, acidosis, and hypotension, persists despite the use of therapies directed at arterial blood pressure, CVP, and oxygen saturation. Treatment should consist of a system-based approach for shock. Airway and breathing, the respiratory. Airway and breathing should be rigorously monitored and maintained for patient in shock. This may include endotracheal intubation with mechanical ventilation, which may reduce the work of breathing and optimize oxygen. During intubation, induction agents, cardiotonic medications, and respiratory support must be chosen carefully so as not to worsen the already compromised cardiovascular status. Vascular volume. The rapid restoration of an adequate circulating blood volume is essential for a patient in shock. Crystalloid solutions such as normal saline or lactated ringers are fluids of choice for initial resuscitation because they maintain intravascular volume. The use of colloids such as albumin or starch to maintain intravascular volume has not been demonstrated to benefit survival. If there's evidence of anemia or suspected loss of blood, packed red blood cells should be given. The initial administration of 20 mL per kilogram of fluid is recommended. Reassessment of the patient's condition based on vital signs and end organ perfusion helps determine if an additional fluid bolus is needed. Myocardial function. Once the intravascular volume is optimized, manipulation of other components of the cardiac output should be attempted. Abnormalities in heart rate resulting in poor perfusion and shock should be addressed. An unstable tachycardia manifested with hypotension and signs of shock should be treated with electric therapy or cardioversion, synchronized cardioversion, or defibrillation per Pediatric Advanced Life Support Algorithms, or PALS. Cardioversion synchronizes the delivery of shock with the QRX complex to prevent deterioration or a more lethal arrhythmia, such as VFib, and should be used in patients who have a pulse. Defibrillation delivers the shock regardless of timing and is indicated in pulseless rhythms that have resulted in cardiac collapse. Hematologic. In hemorrhagic shock or anemic shock, intravascular volume should be replaced with packed red blood cells. Although there's variable data regarding ideal hemoglobin for pediatric patients in septic shock, it's known that mortality rates increase when hemoglobin levels are less than 6 milligrams per deciliter. Provision of blood improves circulating blood volume and increases delivery of oxygen to the tissues. Coagulopathy abnormalities can occur in all forms of shock, and a coagulation cascade can lead to disseminated intravascular coagulation, or DICs, which results in thrombocytopenia, decreased fibrinogen, elevated fibrinogen split products, and hemolytic anemia. In prolonged states of shock, this can occur. The rapid reversal of shock often prevents DIC and bleeding from occurring. Lastly, though there is adult data on trauma resuscitation to suggest that a balanced resuscitation of packed red cells, platelets, and fresh frozen plasma may improve outcomes, this has not been shown in massive pediatric transfusion studies to be the case. Endocrine system. Maintaining metabolic and hormonal homeostasis is important in children with shock. Adrenal insufficiency is common in the intensive care setting, and often presents with low cardiac output and high systemic vascular resistance, or with high cardiac output and low systemic vascular resistance. Adrenal insufficiency should be considered in any child who is unresponsive to catecholamines, and there is a possibility that adrenal dysfunction actually contributes to the development of catecholamine-resistant shock. Hydrocortisone has glucocorticoid and mineralocorticoid effects and should be given at either a stress dose of 2 milligrams per kilogram per day or a shock dose of 50 milligrams per kilogram per day during acute episodes of shock. Electrolyte abnormalities are also common in the PICU, and following their values closely is important. Patients that are resuscitated with fluid, their sodium values may become abnormal and need to be corrected. Sodium, potassium, calcium levels should all be followed. Hypocalcemia is a common and reversible contributor to cardiac dysfunction. Hyperglycemia often occurs as a result of glycolysis and glucogenesis mediated by increases in adrenocorticoid hormone, glucocorticoids, glucogens, and catecholamine, and decreases in insulin during shock. Hyperglycemia contributes to reduced immune system function and promotes microbial and fungal growth. Although there is now more evidence to suggest that tight glucose control may not be as beneficial as one thought, extremes in either high or low blood sugars are not desirable and should be watched. Nutritional status. Nutritional support of a critically ill child has a role in maintaining stability, promoting healing, and improving outcome from acute and chronic illness. Nutritional goals promote adequate metabolic substrate for growth and development of the child. The optimal balance is to maintain an anabolic state with positive nitrogen balance, either enterically or parentally, either through an NG tube or an IV. This includes an evaluation of vitamins, trace minerals, and immune-modifying nutritional agents that do not demonstrate clear benefit. Finally, we talk about ECMO, excorporeal membrane oxygenation. Patients remaining in shock despite all of our best efforts may benefit from mechanical cardiac support such as ECMO. ECMO is highly effective for cardiogenic shock because it helps support an ailing heart, like in myocarditis, but is less successful in septic shock. Patients may still require vasoactive agents for persistent hypotension, but less ionotropic support because the circuit provides ionotropy. Patients in septic shock may require central venous cannulation strategy with VA ECMO to provide adequate flows. This is a high-risk strategy and may not be adequate for patients with refractory vasodilation. Meningitis. What is meningitis? Meningitis is an inflammation of the overlying membranes of the brain and spinal cord, known as the meninges. It can be bacterial, viral, or fungal. Common causative agents for meningitis are age-specific. For newborns, the primary bacterial agents include group B streptococcus, obtained from the mother, E. coli, again obtained through the birth canal, Listeria monocytogenes, and other gram-negative bacilli. In older infants, through the early toddler years, Streptococcus pneumoniae, Neisseria meningitidis, and Haemophilus influenza type B or Hib are the most likely, though the incidence of Haemophilus meningitis has fallen dramatically since the introduction of the Hib vaccine in the 1990s. Following trauma or other neurologic procedures in children, Staphylococcus and gram-negative organs are the most common causative agents. Viral agents include, for infants, infants that are at particular risk for meningitis as a result of herpes simplex virus, enterovirus, parenchymal infections. Pathophysiology of meningitis. The key pathologic derangements of meningitis involve two primary components: disruption of the blood-brain barrier and resultant alteration of cerebral autoregulation. After typically hematogenous spread, after nasopharyngeal colonization, the blood-brain barrier becomes disrupted by the pathogen, the bacteria or virus, leading to an invasion of the meninges. Inflammation of the subarachnoid space happens with accompanied inflammatory cascade. The presence of cytokines alters vasoregulation of the neural area, resulting in abnormal cerebral blood flow and potential alterations in intracranial pressure. So the blood-brain barrier doesn't keep things out that it should and doesn't let it disrupts that ability of the blood-brain barrier to regulate things. And so ICP can climb and can damage the brain. Some general considerations for management and treatment. Infants and children with meningitis may present with acute alteration in mental status. They can be very confused, especially those with bacterial meningitis. This can be seen in older children also with viral infections. There also may be nonspecific symptoms before meningeal signs develop. Meningitis caused by bacterial infections like N. meningitidis may also present with multi-organ system dysfunction and characteristic signs such as pupa, fulminations, or little spots on the skin. If the intracranial pressure is elevated, the patient may have vital sign abnormalities like hypertension, bradycardia, and irregular respirations, or Cushing's triad. Symptoms such as loss of consciousness and seizures are late clinical signs that may be preceded by headache, photophobia, emesis, and alterations in mental status. Laboratory testing. Timely recognition and suspicion of meningitis is essential for successful management and treatment. Early and aggressive antibiotic treatment given given the relative low risk versus the potential high value of antimicrobials. Cerebrospinal fluid sampling should ideally occur before antibiotics are initiated. However, this should not delay giving antibiotics in circumstances where it's not possible to do a spinal tap. Antigen testing can aid the diagnosis of meningitis even when antibiotics have been administered beforehand. Thus, the goal is to treat without delay. Cerebrospinal fluid is commonly analyzed for cell count, presence of organism by gram stain, glucose and protein, and bacterial antigen panels, as well as HSV antigen and latex agglutination testing may also be sent. The role of neurologic imaging before lumbar puncture is somewhat controversial. When patients have clear signs of intracranial hypertension or a focal neurologic deficit, imaging is warranted to assess for the presence of a mass lesion or the associated risk of herniation with a lumbar puncture. There's yet to be any kind of universal recommendation for pre-imaging in children. In most cases, empiric antibiotic therapy with vancomycin or a third-generation cephalosporin like ceftriaxone is recommended. When there is concern for HSV, acyclovir is included, and for neonates, ampicillin is routinely added because of the risk of listeria. Dexamethasone is recommended as an adjunctive therapy in cases of H. influenza to reduce the incidence of hearing loss. And supportive care is recommended as well. Primary complications of meningitis include lasting neurologic impairment, seizures, brain abscess, disruption of sodium homeostasis, and cerebral edema. Timely diagnosis and therapy can help mitigate the worst of these outcomes. Multisystem inflammatory syndrome in children was recognized during the COVID-19 pandemic. With the COVID-19 pandemic, this new shock state was described in the pediatric population, those patients less than 21 years old, and named MISC, or multisystem inflammatory syndrome in children. It's similar to other post-infectious inflammatory syndromes that cause shock, such as Kawasaki's disease, though it was also unique in that the cardiac dysfunction related to MISC appeared to be more related to general cardiomyopathy and viral myocarditis than coronary aneurysms. Again, just to review, meningitis is important to treat quickly and effectively because lasting primary complications can affect the brain. They can have lasting neurologic impairment, seizures, brain abscess, disorders of abnormal levels of sodium, and cerebral edema, including increased ICP. So it's important to treat quickly. Thank you for your time and attention today. This just concludes our lecture on shock and meningitis.